the finance meeting to order. Is there any public comment? Hearing none, next on the agenda is managed care for seniors. Sandy, Bob?
Okay. You want to go first? You want me to go first? Doesn't matter. Go ahead.
I guess I'm first, aging. Okay.
So-
Age before beauty, yeah.
So let me do a teeny bit of framing here. As everybody knows, big developments, due to changes in government legislation, what have you, managed care is now becoming a mandate rather than one of the number of options. And our presentations today are basically to provide the Board of Commissioners with the situation that managed care's arrival is having on our two areas, main areas that deal with seniors. So Sandy will talk about the impact on aging services, and Rob's going to talk about nursing home.
And I'm working with them. This is pretty much Comprehensive Care Connections is the agency that I'm referring to. So there you go. I'll try to condense it. Okay, so yes, I'm here really to present pretty much how aging is now working through the waiver process and how we hope to move forward in the future. Just so we're all on board, Aging Waiver is in Cumberland County, provides services to about 175 consumers. The majority, all of, I guess, 60 over the age of 60. We have 4 service coordinators and 1 supervisor who oversee that program. Now these services, and this is what we're talking about throughout the process of managed care, is for people who are what we call NFCE. There's like alphabet soup. I should have sent that along, but who are nursing facility clinically eligible. That their services actually should be, they do meet the criteria of services for a nursing home, but they're choosing to get their services at home, but they also have to meet the financial criteria of Medicaid, which is really the same criteria that they must meet to get medical assistance payment in the nursing home. Except your home is not considered a resource because you're going to stay in your home. That's probably the biggest difference. So currently we're reimbursed for the service coordination that we provide. It's a fee for service. We're paid about $18 a unit, which is 15 minutes. Travel doesn't count in those units. Helping people discharge out of hospitals doesn't count. So it's kind of difficult at times to meet the number of units that make it profitable for us or make ends meet. We are working towards that. Actually, a service coordinator has to bill 425 units in a month, which is a good number. Managed care is going to change that. It's going to change our approach. There will be higher standards, and there will be actual performance measures put in place because we will be looking at a value-based payment system for the managed care. So why managed care? Well, of course, the state of Pennsylvania is trying to find a way to reduce costs and still provide quality services to older adults and people with disabilities. So the state in it was 2015, Department of Human Services and the Pennsylvania Department of Aging collaborated and came up with the managed care product called Community Health Choices. That's bottom line is they want to ensure that older adults and people with physical disabilities are able to stay in their own home. That's where they would prefer to get their care. It does not mean that they would not need to go to a nursing home. It has to be a safe environment. They have to have their needs met with the formal and informal supports that are provided. So Community Health Choices was announced that they would put out requests for proposals, which they did, and about 20 managed care organizations jumped on board, large insurance companies. Of that 20, they did put out their bids and offered contracts to 3 of the 20. So right now everything's on hold. We're talking about a $5 billion contract now divided by 3 managed care organizations. So There are at least 6, the last I heard, who are appealing the bid process. So I just give you that. Yeah. Who are the 3? The 3 are UPMC for you, which is out of Pittsburgh, University of Pittsburgh. Centene, which is new to Pennsylvania in a sense. They are pretty nationwide, provide services across the country, I think in 17 different states. And then Veritas, which is, Cumberland County is familiar with them because they are a behavioral health provider in the managed care for behavioral health. They're part of really Independence Blue Cross out of Philadelphia. So I kind of look at it as we have Pittsburgh, we have Philadelphia, and we're the middle. We're the flyover zone of Centene now. And I would tell you too, Centene is very high tech. They are, and again, we're not real familiar with them, and they were not a group that was at a lot of the meet and greets. The AAAs became very proactive in trying to determine how would we be able to be part of this managed care picture. We are called Lehigh Capital. Our managed care region is Lehigh Cap. We had, as we called it, a meet and greet. It was like speed dating with the insurance companies, and we sat down and talked to them and said, oh, this is what we can do for you. And they said, thank you very much. And from that, what we did really determine is that the AAAs definitely are committed to wanting to continue to serve frail older adults in Pennsylvania who would be enrolled in the community health choices. Now the Southwest, Pittsburgh, has a lot more, I guess, skin in the game at this point. They got much more proactive than just speed dating. And they started some very serious conversations with P4A, which is our provider association, Pennsylvania Association of Area Agencies on Aging. And they realized that any individual AAA, it would be just an unsurmountable task to try to contract with the MCOs on their own. So that is why we have C3. That is what these discussions brought forth was C3, Comprehensive Cares Connections, which is bringing all these AAAs who are interested in providing service under one organization. It provides obviously a broader geographic reach across the state, and really helps with the systems and efficiencies needed to contract with the managed care. C3 has done a lot of legwork already. They've done a lot of market analysis and research. As you can see, this is their nice little handout that they put together. It really does give you a good idea of really what I'm bringing to you today. I really think that C3 will strengthen our network and actually offer potential for needed revenue in the future. Now, I said Southwest is 2017, Southeast, again, here we go, the East, the West, so the Steelers, now the Eagles, are 2018, and then us in the middle are 2019. So January 2019 is when we would be part of Comprehensive Care Connections. But in the meantime, I think that looking at how C3 will strengthen the whole network, and I think will actually bring, hopefully, a potential for additional revenue in the future, because as we know, our regular aging programs are pretty much flatlined at this point with no real increases in the near future, I see. So definitely by becoming part of C3, by joining C3, it will give us greater leverage. We bring with us, and the reason the MCOs like the AAAs is because we are providing this service already. So we bring to them the consumers, and we bring to them consumers who actually are very familiar with us. We have consumers in the aging waiver who we've been providing services to for more than 5, probably even 10 years, some of these folks. The under 60, some for 20 years since the program began, or almost 20 years. So there's a lot of benefit to that, which also will give C3 a better ability to negotiate contracts with what we're bringing to them. Also, the MCOs would much rather deal with one than how many AAAs. It's just an ease of that. Are the quality assurance and standards that are required to be part of C3 will also offer a consistent level of services throughout our agency. And I think the best practices that we glean from C3 can also be used in our options and nursing home transition and other care programs. So C3 will also offer the contract negotiations, the billing, the member payments, legal and actuarial, and probably one of the biggest ticket items is the IT and data warehousing. Because each MCO, if it sticks with the three, I don't know if that appeal process will change, but each one of them will bring their own billing, should I say nightmare? Yeah. So that is something that we would not be responsible for. We would just be providing a service position. So that's the sunny side of the street. So are the risks, absolutely. The first being, will C3 be successful in procuring favorable contracts with the MCOs? There's also a risk of non-compliance with any member AAA that becomes part of C3. Now, C3 will be there to enforce the inclusion criteria and be monitoring constantly, but if a AAA falls short, it could be a problem that all across the network we would feel. They do talk about the risk of providing to under 60. That's not a risk for Cumberland County because we've been doing it. Most AAAs, in fact, we're the only AAA in the state that does provide for under 60. And if you think, well, what's so hard about that? I think under 60 with the disability and the aging population, it's kind of like apples and oranges. You probably can see that in the nursing home sometimes with just a different mindset, and it is difficult, but we're good at that. So we don't see that as a risk. We see that as a positive. And C3 realizes that they can't go to an MCO and say, we would just like to take your aging people. Even though, again, that is the biggest piece of the pie, is that the aging waiver. C3 wants to be flexible for our members, so signing up with C3 doesn't mean that you can never leave them. But there is that risk that AAA that might leave could be a service gap. It also expands where we go. Again, geographically, most AAAs are stuck in their region, although a lot through service coordination have expanded outside of the county. We've been doing that for years with our under 60, providing service in Perry County and Dauphin County. So again, that's not something that's difficult for us. I think some of the staffing guidelines really have not been answered. I think that's probably one of the biggest nuts we might have to crack. C3s, because it's more of a medical model, does want to look at licensed social workers. We do have licensed social workers on staff currently that we could utilize to provide services. But right now, the Department of Human Services has said you do not have to be licensed. You need 3 years of experience before the contracts, which we would be grandfathered in. All of our staff do have that experience. Now, if the MCOs change their tune and say you absolutely must be a licensed social worker, that could put us a little at risk there. So that is, but it is a priority of C3 to work through that staffing situation. So, you know, should we continue to provide service coordination? I know we will through 2019, at least as far as I can see it now, but my belief is that's how we're going to ensure that the needs of the consumers that we are currently serving will continue to be served. You know, the consequences of trying to transition to other providers would be difficult, and I kind of liken it to right now the nightmare we're going through watching enrollment being taken from us, which we were doing very successfully, getting people enrolled in programming. It went to the Pennsylvania IDB Maximus, and it's been nothing but difficulty since April. People are falling into black holes. People are not getting service. Vulnerable people are not getting service because they can't do the job, which I know we can and could continue to do under service coordination. Of course, this does come at a cost. And the last, wait, did I change? Yeah.
Before you get into the cost,
Yeah.
because that's going to be
Yes.
the grand finale. We don't have to do this.
Correct.
This could, so I think if we do this, i.e. get on the managed board, the managed care train, it makes a lot of sense to do the triple C. But we don't have to do this. and I'm not saying we shouldn't,
Mhm.
but I think you laid out some good humanitarian reasons to do this, okay? Our ongoing relationships with people, our desire to provide them a good service.
Mhm.
Is there a business case that can be made for us wanting to be successful in managed care versus is this an opportunity to get out of something that from a business case
Mhm.
might be beneficial?
I think that, which I mentioned briefly, is the fact that this is an opportunity to make money, in a sense. I mean, we could, through good practices based on what, and there's a lot, I don't have a crystal ball, but, you know, at a good reimbursement rate, and if we meet the inclusions, we could, as we have in the past with Waiver, because it's value-based now, so we're gonna get so much money. Instead of units and worry about 15-minute units, it's going to be a value-based system, and we would be able to have more money at our fingertips to provide services to others, like options. You know, if getting out of service coordination, we're looking at, we still are required to provide our options, the Older American Act programs, which is options, which is very limited, couple hours a week in the home services, the legal services, which is very, very limited, but we do it, ombudsman protective service. And I think too, that protective service piece, we're seeing it even with Maximus, when you can't get people to the service that they need, caregivers burn out, neglect occurs. I think it's a cyclical type of event, although again, I'm on the bleeding heart, not the business model, but I do think that it is a positive business move for us, but one that doesn't come without risk. I mean, that's, if we don't do it, we will be a much smaller agency providing what's required by the Older Americans Act. Nursing home transition and care transition, two programs that we have been doing, will probably end up under this umbrella also. So it's not just service coordination. I think it's the opportunity to provide other services that we have been providing and could continue to provide.
I think, you know, my big concern is that we could be incredibly successful at this and then wind up under a big, you know, financial burden. That doesn't seem to be the case.
Mm-hmm. Mm-hmm. Yeah, I would hope not. Yeah. That last page, and as we said, the page with the black and white printed after that is this is really laid out of how C3 has divvied up who owes what to be part of the cost share, to be part of the initial investment. As you can see, someone like Allegheny County is at $300,000, and this is really based on the numbers of waiver consumers that we are providing. Adams County is a flat $5,000 because they do not do service coordination now, but believe that that is something that they would want to be part of in the future. These are just the AAAs. Some profit, some private nonprofit, and some county. It's about split down the middle, who have signed, as we did some months ago, a letter of intent or a memorandum of understanding. So these are the people who they are hoping to all will move forward. Of course, Allegheny County being the biggest one, my understanding is they really are on board. They've already done a lot of in-kind service. We have been helping with some work groups, and bylaws are being done. There's going to be a board of directors. We, as initial investors, would be part of the governance. We would get a seat on the board to continue to make decisions moving forward. And we also, back to finances, if we would once, not if, Jason Kunzman, who is the director of C3, the hired person that they're paying out of P4A dues. Lost my train of thought there. Where was I going? Oh, when we make money, when we break even, initial investors So right now they're suggesting that Cumberland County would pay $15,947,000 once it turns and we have contracts with MCOs, the initial investors would get back their initial investment over the course of time. And they don't have details of that or when that would happen, but that's a little cherry on the top, right? But that, and then, did I hand you that other paper? Yeah, the tiers. This is what the governance, again,
So Sandy, I'm sorry.
I'm sorry.
So again, from a business model, so CCC sees itself as potentially being self-sufficient.
Correct.
And what you're providing by the startup capital.
Right. This is a one-time
And a potential promise to be
reimbursed. Yeah. This is startup costs because once we are a provider agency, it would just be coming back. And then there are some different investment opportunities. Those 4 tiers is what the governance, we had a meeting and found these to be a good way to move forward. Being tier 1 is if you're all in by November 30th, you get it all back. It's pretty self-explanatory there. All of them, tier 1 and tier 2 and tier 3 are really the only ones that we would even be eligible for. I will tell you that tier 4 was really developed, and if you notice on this paper, Southeast is not represented. Southeast is Philadelphia. Philadelphia alone has more than 10,000 aging waiver consumers. So their buy-in would be a little more than $1 million. So they felt that wanting to get Southeast in, they would develop no upfront and just admin costs to try to bring that down. So that's why.
So they're setting up a separate.
No, they have not said that yet. Yeah, for the nice, friendly aging network that we hear about all the time. My first meeting, I'm like, Southeast isn't playing very nicely, and no one has really said. She did. Jason did share with me a letter from Holly Lang, the AAA director at Philadelphia Corporation for Aging, who basically says, I support everything you're doing and your work is great, but we're not committing at this point in time. And there's probably some underlying thoughts that the Southeast might be doing their own thing. But we have no clue what that might be. And they have time because they have another year and a half at this point in time.
Cindy, I had shared with my colleagues a little bit from my liaison report from the Aging Advisory Board.
Right.
And I didn't get down into all I used the word the weeds in connection with all this. But I guess, in looking over this list, I count 37 of the 52 area agencies of aging. Kind of like what jumped out at me is I don't see Dauphin County in here. Do you know what they're up to or what's going on there?
I'm sorry, I don't have a real specific other than just they don't do service coordination now. They've been out of the business. So I guess it's just they're not seeing it as something they want to do. Yeah.
Now, you said currently we have 175, waiver citizens that are taking advantage of the Medicaid waiver.
Correct.
Which essentially they're all nursing home eligible, but they're receiving services in their home.
Right.
Based on the fact that I think part of the goal here is, to continue to address the whole rebalancing effort, statewide, because we have a lot of folks, in our nursing homes who may be served, in their homes if the services were available.
Right.
Are we anticipating as a result of all this that we're going to have, a lot more waiver folks that are going to, essentially receive the services they need in their homes and therefore qualify for the aging waiver?
I believe that. I think that's really the focus. And in fact, the assessment process, which is changing and was supposed to be done by September and now it's May, but the assessment process is actually being simplified to probably address what is nursing facility clinically eligible and being able to get more folks into the waiver program. Yeah, because Pennsylvania's been pretty slow at the rebalancing efforts, but.
Well, but I also understand that from everything I've read on this is that because our 85 and over population is the fastest growing segment of our population, that there's going to be an ongoing need for 24/7 skilled nursing home care.
Mm-hmm.
That need is not going to go away. But with those of us in the baby boom generation coming along, that this is a way to try to maybe you won't end up in a nursing home unless you absolutely have to.
Right.
And the focus is to provide community-based services for folks to have the opportunity to stay in their homes as long as possible. Now, you talked in terms of, you made some kind of a comment about saving money, or us earning more money or something?
Us being able to use
Okay.
proceeds from
All right.
other services.
Okay, so if you could, we're not really in the business of making money.
No.
So could you
No.
explain that a little bit further as to what it is that you're talking about and how it is you see working to the benefit of our seniors?
I think if in fact we are able to, not making money, so I'm, if we can provide the waiver services and have resources left over, so to speak, they can just go into our options, it can go into our funds to provide services that are not waiver related. I mean, we're basically relying on lottery funds right now, which we know are being eked by medical assistance. We know that because that's considered home and community-based services. So the options programs and the options services, and there are people that little bit of help sometimes that we can provide under option services, that couple hours a week, we would be able to use the funds in that way. I'm assuming, and that's how C3 is presenting it, and yeah.
All right, so I guess, and correct me if I'm wrong with this, if this is not a fair analysis, but essentially what we're saying is there's, limited dollars that are available for these services. More and more is being taken out of the lottery for long-term care.
Right.
But doesn't this really come down to, if we are not participants in this, and we essentially close up shop, that we end up in a situation where perhaps we're not drawing down our fair share of resources to serve our seniors here in Cumberland County. Is that a fair way to
Yeah, I
describe
think
it?
that's fair, absolutely, yeah.
And the other question I'll ask is and then my colleagues may have some additional questions, but the other question I'll ask is, in terms of our involvement, okay, this is also our way, essentially, to make sure that our seniors are receiving the services that they deserve. If we were to essentially say, we're not doing this anymore, that's it, we're done, okay? And essentially, the county washes its hands and says, go ahead, managed care companies, you do whatever you want to do, right?
Right.
So this is a way for us to actually fulfill our obligations with respect to making sure that public funds are being used the way that they should be used and meeting the needs of our seniors, as opposed to just shifting it to some private organization to.
Right, and we've seen over the years with Waiver, first of all, a lot of private organizations, they've come up and they just aren't successful because it sounds like maybe an easy thing to do. It's not easy to provide services to people in the home and to manage that service. And we've seen agencies come and go. They choose our agency because they know us and they know that we provide a good service. And I do think that your point is well made, that it does guarantee that the money's being used for the seniors.
And the reason the MCOs would consider using AAAs rather than doing it themselves?
Well, I think the fact that we come as an organization we're vetted, they know that we know the consumers. They do have a 6-month, I'm trying to think of the word, it's funny, on the way here I was driving myself crazy trying to think of it, but guaranteed, let's just say that once this transition takes place, we do have a guarantee of 6 months. Like, so when providers, like, so now they want to make a choice, like, do you want to try somebody else or do you want to stay with who you're with, that you've been with for 6 months? The MCOs must give us 6 months. The MCO must give us 6 months. And again, we are providing, the AAAs are providing the majority of services in the aging waiver across the state. And the MCOs, UPMC is already working with Southwest in certain programs already with nursing home transition, I think, so.
One other question, I know it's kind of like off the track a little bit, but
Yeah.
I think it's important. Could you boil down, again, in layman's terms, what the issue was? Because I've heard this from our county commissioner colleagues from throughout the state, the Commissioners Association. The issue with respect to Maximus, what exactly is going on there, and what is being done to resolve? What is the issue,
Okay.
and what is being done to resolve that?
Okay. The issue is, in April, Maximus became the enrollment provider. So they were going to enroll all the aging waiver consumers into the aging waiver, which means not just getting the assessment done, which the AAAs do, but making sure that the people have the paperwork done for medical assistance, and then setting up what we call the initial care plan. I can't tell you what the problem is, other than Maximus was totally ill-prepared for the sheer volume of people that are seeking service. Their call center was not equipped to meet the needs of the callers. People, and that's really simplifying it, but you know, across the state, yes, the AAAs are just, we are reporting this to DHS, to Office of Long-Term Living, to Department of Aging, and they are basically saying, show us numbers. And we have numbers, they don't like the way we're showing numbers. Maximus is saying, but we are improving, and they're looking at the fact that they're answering calls now in 18 seconds now instead of 38, and they're not dropping as many calls, but people still are not getting enrolled. We have had people who we have sent the paperwork 3 times. We've done the assessment, we've had the signed sent, and it just gets, we have faxed it, we have mailed it, and we have email scanned it, and it does not get delivered. There is word, there's possibly going to be a Senate hearing regarding this whole debacle, because it's been just, you know, it's just been difficult. And we have people, we just got paperwork from someone who applied in August, and now they're just getting approved. But we're still not sure if they picked us as a service coordination agency. It's just, nothing seems to be working. And as much as aging, now one of the things, and they thought that they were trying to say that it's because the 600 doesn't get done, and they were very clear that they weren't going to pay anyone, especially the AAAs, to complete the 600, which is the financial paperwork. Even when the 600 is completed by aging and handed over to Maximus, it has not sped up the process of, thank you, the process of getting people enrolled. So I really don't know what's happening behind the scenes. We just know there's a lot of frustration, and
Do you have any idea on how many seniors total in Cumberland County who applications where they try to enroll and they haven't been able to?
I can get that for you because we've assessed them, yeah. And we are keeping track. We upload that to the state quarterly, we have, and they've got numbers. Yeah.
Thanks, I appreciate it.
Sure.
Get that.
Yeah.
All right, we'll take up too much time.
So Sandy, we had to sum all this up. The mission to our seniors, managed care is coming.
Yeah.
If we do this, we won't lose our shirts, hopefully. We will be able to do so better if we join Triple C. It requires an upfront investment, which we may get back. And this is, if it all goes south, for whatever reason, we can extricate ourselves from it at some point if that makes the most sense to
Yeah, we are not, anytime you can get out.
you.
Yeah.
When do you need, when do we need, or we've at least preliminarily indicated the rent we're going to be participating.
Yes.
So when do you need the board to approve this?
So we can have money by November 30th. And I'm still trying to, like, we went from 17 to 22 and now we're down to 15. So the number's still kind of in flux depending on how many people sign on. But right now, the latest one is what I've given you as of October 2nd is 15,947. And to be considered an initial investor, a tier 1 investor, it's by November 30th.
So if we put this on our workshop meeting next Thursday, decided on it a week from Monday, would that be enough time? And you would have a decent idea of what the final number is?
Yeah, I would, yeah. Yeah.
If this is going to, if the actual dollar figure may end up changing, maybe there's a way that we could, word the motion to say not more than, or
Yeah.
something like that.
And I would definitely do what I could to get specifics.
Well,
Yeah, but yeah.
whatever, staff's recommendation is on that, just to, I think to cover us, in terms of what it could be, but it's all based on the number of waivers that we currently.
Yeah.
Gary, do you have any questions?
All right.
Okay, I guess we can move on to Bob.
Okay. I'll try to keep it brief, but I think Sandy has kind of laid, thank you for laying the groundwork. Managed care, I think, it's safe to say in every arena, at this moment is very frustrating. It's a moving target. You have no clue what it is today, where it's going tomorrow, who's going to end up doing what you're going to have to do to get payment, and there are some providers in long-term care that are providing the services and are not getting paid. Just to give you an idea where we are right at the moment, we have 5 Medicaid MCO contracts. It's Medicaid. Our average reimbursement for what business we have been doing in managed care is $213.65 a day, which is generally our current Medicaid rate. It's not much better, it might be even a little lower. We have currently 9 Medicare managed care contracts, with Optum supposed to start on December the 1st. Our average Medicare reimbursement is between $330 and $548 a day, which on average is 94% of what our traditional daily Medicare rate is. So we're not even really, on the average, not getting even what we're getting currently in traditional Medicare. Where that's going to go, I don't know. We are not very attractive at the moment to a lot of managed care organizations. Some of their criteria for long-term care is that they look at the government's 5-star CMS rating program. And like I heard Sandy say, they don't want to deal, the managed care companies do not want to deal with 8, 10, 12 different companies or facilities. So they're going after the 2, 3, 4, 5-star, maybe 4-star facilities. Currently, our overall rating is 2 stars. Although our quality of care is 4 stars and our staffing is 3 stars, our overall is only 2, which really for their publicity and their operations, we're not really an attractive player for them at the moment. We have been, since I've been with Claremont, the most we've ever had in any one given day is 9 commercial residents or 9 managed cares. Today, we're at 8. Our overall census is 275. So doing the math, we're less than 3% of our population today is managed care. And I have a waiting list right now of traditional Medicaid residents that I could easily fill those beds. But to continue to do the managed care business, because I agree with Sandy, this is something that I think we don't know where it's going to end up, but I don't think it's going to go away. We will always have it in some form. It is the insurance companies, I want to say this carefully, their financial model in order to curtail cost and generate their profitability. They are based on dollars and cents model. They are really not based on the medical model. Yes, it is concerned about medicine, but on the other hand, ultimately the bottom line comes to their dollars and cents because they're paying the bills. That's very simply put. What are we doing to become a little more attractive to managed care? We are trying to improve the 5-star rating system. We look at that now daily, and we're doing what we can. Some of the items like the survey, you know, our annual survey is coming up, and that does play a part in the overall rating. So we are looking at the 5-star rating program. We're trying to do the best we can. Also, right now, our therapy department is short-term, we're at 18 days LOS, which is length of stay. The managed care organizations really want their participants to be at 14 days average length of stay. So we are working with Functional Pathways, our rehabilitation provider, to try to lower that further. We have lowered it since I've been there. It was 21 days when I got there. We're now down to 18. We're trying to get it to 16. Then we'll try to ultimately get it to 14 so that we can be a little more attractive. So we are working on the rehab. And also our numbers in rehospitalization and the antipsychotic use, which are big deals for the managed care companies, we're good, we're okay. We're not fantastic, but we're not bad. So we're working with Dr. Gullis and some of our other attending physicians to look at these, because both of these are not necessarily totally driven by the physicians, but they have a big part to play in the rehospitalization and the antipsychotic use. So we're not bad, but we are working to try to get them down to become more attractive. Again, what does the future hold? I don't know. Other than I do believe, and I just attended the Pennsylvania Healthcare Convention 2 weeks ago, their opinion on the for-profit side, their opinion is, A, managed care will not go away. And their opinion is that within about the next 5 years, they're saying the potential exists that managed care could have 50% of the healthcare market. Right now, it's not affecting us a great deal, and we could survive and probably even thrive with just a little bit of managed care that we're doing. But I don't know where it's going to go. And I can give you, I talked to Lisa Spence last week, and she relayed a story to me, which I had not heard in the last couple of years. She was, and I believe it was Pinnacle West Shore. The hospital there admitted a patient, managed care patient, for rehab. Long story short, they could not or did not rehab the patient in 14 days. The managed care insurance cut the patient, which means they had no payer source. The patient and or family went and applied for Medicaid. So literally, Pinnacle West Shore now has a Medicaid pending long-term care resident in one of their short-term rehab beds, now clogging up their rehab unit. I only bring that to your attention because if that is something that the managed care companies continue to do or start to do with the providers, they could literally kick themselves in the teeth. Because then the providers are going to say, you know what, I don't need to play that game. I'm just saying that, so thus to go back to my comment to you, I don't know where it's going to go. I know the premiums for participants in these managed care programs are going up. My question then would be, to what point is the saturation point that someone is no longer willing to pay for that managed care product? I don't know. I have no idea. So that's kind of what I see going on there. So whether managed care, maybe because of their behavior, will it slow down? Maybe. Will it decline? Maybe. Will it stop? Maybe. We just don't know how that will go. So for brevity, what I would say to save us all a little bit of time, we need to pay attention to our contract administration. We need to pay attention to our reauthorizations that our RNACs get to continue the therapy to make sure we're getting reauthorizations. We need to start trying to get the higher level of reimbursements. Not that we're going to get them, because it's very hard. I heard Sandy talk about tiers. We're in the same boat. Ours is called levels of reimbursement. And not that I think we'll get the higher levels, but we at least have to make a case and present our case to the managed care companies and say, we think we deserve level 3 money for this particular case. They're probably going to say no, but it's anything else. You ask for the Cadillac and hope that you get the Chevy. And we need to align with the managed care companies with our rehab. We've got to get down to the 14 days or they're just not going to want to deal with us. I think it's safe to say we will not get rich. I don't think anybody is going to get rich doing the managed care business. I think we're going to do it to be a participant in the arena so that we're not left behind. We will not make a huge fortune out of doing that business, at least not in my opinion.
What about managed care on the Medicaid? Managed care on the Medicaid side. Managed care on the Medicaid side.
It's still, we still have to play the game basically by the same rules. And we still have most of the requirements. And the reimbursement is not, I would rather really not have to do it because it's less, I think it's actually less, and maybe Dane I saw in the back, I think we're getting $215 on our traditional Medicaid rate. Here, what I got was $213.65. So to me, I would rather not even really do that business because I'm not making anything. I'm losing, I think, I'm losing $1.35, I think.
So the problem is, it's like the old economists say, if I owe you $1, it's my problem. If I owe you $1 million, it's yours. If they control 5% of our patient admissions, we have options.
We have
if they
options.
control 50 to 60 or more percent of our admissions, it is our problem
That's correct.
because they will go elsewhere
That is correct.
to place their patients. So this is kind of like a very, very big deal.
Mm-hmm.
I think we all talked about, yeah, we were doing a pretty good job of running things in the traditional mode, i.e. where most people either come in through straight normal Medicaid or through private pay or for insurance or what have you. But the fact of the matter is that's probably not what it's going to look like.
Not in
in the end.
2019. Not
Yeah,
in
not
2019.
19.
In 2019,
Yeah.
all Medicaid will be through one. Right now, it
Those three.
stays these three.
Right.
And the whole idea is to be value-based and keeping people out of nursing homes, going for rehab, going for respite, because that's part of the waiver now. They do recognize that people do need respite care. And it's just, and we have contracts. I mean, we do that with nursing homes for the waivers. And all dual eligibles. I mean, that's why this is a $5 billion piece of pie.
And we don't know really what's gonna happen to the
Right.
lawsuit, or the
Right.
participants of the lawsuit is still out there.
Right.
And that could set precedent, and I have no idea how that's gonna end up, and really don't know what eventually gets.
Right. Although OLT, I will tell you that it's not going to have any effect, and they're going to move forward, and July 17, Southwest will be part of managed care. But yeah, I mean, it is, I think, and I think there would be, you know, and it's, of course, it's about consumer choice, although you get a choice of three. And they're saying that Maximus might be the enrollment, so you probably will never be enrolled though.
And they're having trouble enrolling people
Right.
now to begin with.
Right.
So on the waiver side, we have a movement by, on behalf of the AAAs to provide an umbrella
Correct, yes.
that would
yes.
give you economies of scale that you wouldn't have.
Right.
Is there anything like that going on the nursing homes?
Not that I'm aware of.
So basically, it's every nursing home.
It's every nursing home, yes, sir.
Mhm.
It's every nursing home or every long-term care company for itself. That's correct.
And I think you folks, so you're already billing other,
Yeah,
you
we're
were,
billing
you
other
had
entities.
things, AAAs don't have the ability to
So
just.
I'll ask you the same question I asked Sandy. This is kind of a crossroads moment for us, or it will be by 2019. So the question becomes, can we compete in a managed care dominated marketplace? And you know, you mentioned we got to get in rehab, which is for Medicare. You know, we got to get the debt level down. We need to get the star rating up. We need to get the
Antipsychotics, the rehospitalization.
and everything else to the right mix.
We can.
We
We can, but it will take time and it will take effort to do that. If that's the way it shapes out, we can, but where we are right now, I think it's as much as we are not attractive to managed care companies. Can we get there? Yeah, we can if we have to.
What are the top three things we have to do to be attractive? I mean, do we need to take over? Do we need, what is it that we need to do? Is it cost? Is it 5 stars? Is it, what is it?
It definitely is the 5-star rating system, which is one of those things that everybody goes right to. Even though I can be a 2-star facility and be a very good facility, but because the 5-star rating says we're 2, everybody just assumes that we're not that good. So I would say that is the first thing that we have to correct, is through our quality measures, continue with improve the staffing, continue with the staffing, have improved survey results, which I know last year's survey was good, but it hasn't hit the star yet. So that's number one. Number two is, I think, on the marketing side, instead of focusing on what we're not, we need to focus on what we are. Produce some literature and whatever that we can get out to promote ourselves. As we're just not 2, we're doing this, we're doing this, we're doing this, we're doing this, and we're attractive, and why don't you come talk to us? And then the third one, I think, for us to be successful is through the RNAC department. Instead of just sitting back and saying, okay, we'll accept your $300, this is what we're seeing. And we're thinking we need $400 to get that extra generated revenue, which they have not been doing in the past. They've just been accepting what has been put out there, and it's not even saying we will get it, but at least making that effort to get it. I think that's kind of the three that we would have to look at the top.
So let me ask this question, since we know this is gonna, you know, I mean, we'll have an opportunity to see how this is working out in southwestern Pennsylvania.
Right.
Maybe what modifications, you know, they might make as this is all implemented. But, you know, if this is to go into effect, you know, here in July of 2019.
Actually, January 19. They backed it up just for this, just for Southwest.
I thought that was. Okay, so this.
Yeah, so it's July 17, then January 18th and January 19th.
Okay.
That was
All
the
right.
original, yeah, so whether they, yeah, it changed that because they said, no, we're not changing the other start dates, but
Okay.
6 months,
So-
yeah.
All right, 6 months. When do we need, with respect to nursing home, et cetera, when do we need to be prepared to present our case to these 3 MCOs?
I would probably say 6 months prior to, we need to have our packet together in order to present to the various companies that we want to deal with or to continue to deal with. So I would say probably middle to the fall of 18. And that's, again, that's a basic guess.
Can I, the people that are already in-house and have to pick from one of the 3 MCOs,
Yep.
they're,
They'll fall right in.
they will be part of that, and
That's correct. They will be given a choice of whoever the 3 turn out to be.
Yeah.
They will be given a choice, just like Medicare Part D
Right.
for your medications.
Right.
Here's your 4 or 5 or 6 or 8 plans, and you pick one. And that's what they're going to do.
So I'm a long-term resident. I have to pick one of the 3, and none of the 3 have contract with our facility. Do I have to move?
You'd have to move unless, that's correct, unless we had an agreement with one of the 3 that they would have to move. Correct. Now, if anybody has been in with us for any length of time, the chances of them moving are probably, they wouldn't do it unless we would have to force them out. But yeah, they'd have to pick one of the 3.
any willing provider.
Any-
That's the
right,
word I was
that's
trying to
the
go with,
language,
any
yeah.
willing
Any
provider
willing
is the
provider.
language. For 6 months, they must at least,
Right.
they have to provide any willing provider.
I'm sorry, why isn't PACA doing something like Triple C is doing for Triple A's?
I do not know.
Has anybody asked them?
Not that I'm aware of, no.
Because your for-profits got big bucks, and even some of your non-for-profit private have access to multi-facility systems and charitable contributions.
I can certainly send them an email, and, I mean, they send me an email once a week, once every 8-10 days. I can certainly respond to it and ask for whatever literature, or whatever position papers, or whatever they have on managed care. I can easily do that. It's not a problem at all.
Yeah, I think it's worth exploring that if the, publicly owned nursing homes can kind of stick together here. Just like the triple A's.
It's not that crazy in the land.
No, I know. And actually
There's
see.
2 sides to the same point.
Mhm.
You want to keep the people out in the homes that you can, but there's still going to be a lot of people
They can
in
stay in.
SNFs.
Mhm.
One would think,
Right.
I'll do that.
I mean, one of the things that you mentioned, Bob, and look, I can't imagine somebody who was, essentially been a long-term resident of Claremont, right, who is on Medicaid, right, having to move. That just blows me away, even thinking about that. Because this has been their home for, who knows, maybe 5-10 years.
I agree.
That doesn't make any sense to me.
No, and I would think that would be a backlash. I mean, somebody would get the whip off of the action of that. If that were to make the newspaper or the TV or the radio, somebody would take a hit
it
for
would be
it.
a big deal for a few weeks, and then it would be gone.
Yeah.
If these guys are in and are in to stay, they have taken into account that there's some, peripheral damage, some, that they're gonna have to take a hit on.
Yeah.
But if their long-term goal is, and they have the sanction to, from the government, to implement this across the board, the fact that it is inhumane to do it.
Absolutely.
Is gonna pale in.
Absolutely, and as I started my presentation, it's a financial model. It's really not a medical is secondary or even third down the list. This is strictly a financial profitability model, that's what it is.
And that's,
Value.
that's where we come in, and I think where we need to speak up. I mean, there should be no reason why, if this is going to be transferring over to the managed care organizations, why folks that are currently on Medicaid should not be grandfathered in some way, shape, or form, so they don't have to move, out
Well,
of
and it begs the question of what nursing homes in Cumberland County will be open to accepting more people on managed care. I mean, you're not-for-profit, some of your, a lot of your homes, they have their numbers. They're not going to take people under managed care. We have a very large Colton Living Center, which is probably 90% MA, maybe 98. They close their doors because the MCOs aren't going to work with them. I don't, yeah.
Yeah.
And I think you make a good
that's
point
right.
that the Southwest,
Any number of nursing homes may no longer be in business.
Right.
Yeah, and Golden Living, I'm sorry, Golden Living is one
Right.
that is currently under investigation.
They might not be in
They may
business.
not be in business.
You might be filled up by,
This is where I would take issue with what you said. It isn't just a financial model. The fact is, there's an oversupply currently in our town of beds. Number two, there's huge variations in quality, and there's huge variations in cost effectiveness. Now, this may not be the best way to get it, but we cannot point to the current system as being optimal by any means. So this is what you get when you don't get your own act together. Not so much us, although we clearly, we need to get up to those measures, and then we can say that, we meet those qualifications, and regardless of how good we think we are accepted by the payers as being such.
right.
Hey, Sandy and Bob, thank you for your information. You're very helpful. Is there any other business to come in front of the board?
I just would like to say this, that I think it's important we stay on top of this and that, we continue to receive periodic updates from both Bob and Sandy. Thank you.
Absolutely. Thanks, Jim. Okay, is there a motion for adjournment? Thank you.
We'll put this on Thursday for workshop.
Oh. He was writing me notes in the air.